right, good morning, good afternoon. Thank you for the opportunity to present. So I have no financial disclosures relevant to this talk. I would like to add that I'm 5'4" when I'm stretching the truth, which is perhaps the most relevant here. So today I'll speak to our second objective of this session, which is recognizing some basic ergonomic risk factors in the operating room, specifically with respect to gender. As we've discussed, the operating room is a complex environment that increasingly relies on the interface between human and machine for high-stakes decision-making. Because the opportunities for error are frequent and the consequences potentially grave, the accurate presentation and interpretation of the human and machine interface is of the utmost importance and must be optimal. Only recently has optimizing this interface for the end user or the surgeon, who is in this case the decision maker, effector, and affected, gained credibility. Nearly 3 decades of surgical advancements have demonstrated that the cost of conditions ergonomically unfavorable to the surgeon cannot safely be disregarded, such consequences being felt by doctor and patient. The widespread acceptance of minimally invasive surgery has forced upon us new working conditions. The surgeon's hand-eye motor axis is no longer aligned. Our visualization, and thus our perception and decision-making, is now dependent on a video display monitor. Our tactile experience is completely altered. And the equipment in our workspace, novel instruments, towers, and cords, have created new workflow problems. Hospitals worldwide found their current OR design did not allow for safe and comfortable workflow during MIS procedures due to inadequate floor space, insufficient position, number of monitors, and the limited range of table height. What has been so good for patients has ultimately been a pain in the neck. Among surgeons who regularly perform minimal access surgery, as many as 87%, as we have seen, report injuries or symptoms related to job performance. Furthermore, symptoms have been found to increase with increasing case volumes. Data suggests, however, that this 87% is disproportionately distributed among female surgeons, some 80% of women and 20% of men reporting difficulty using laparoscopic instruments. Women are experiencing more ergonomic difficulties than men, for whom the operating room and surgical instruments, though uniformly perilous, have more traditionally accommodated. 2,000 SAGES members were invited to participate in this ergonomic survey, 54 of whom were female and 260 of whom were male. This represented a 16% overall response rate. The demographics among participants are summarized above. Women were significantly younger, shorter, had smaller glove size, and fewer years in practice than the men surveyed. Of women reporting, 86.5%, comparable to men, attributed physical discomfort to laparoscopic operating. When men and women of the same glove size were compared, women with a larger glove size of 7 to 8.5 reported more cases of treatment for their hands than men of the same glove size. Women who wore a size 5.5 to a 6.5 surgical glove reported significantly more cases of discomfort in their shoulders than men who wore the same surgical glove size, demonstrating that one glove does not fit all or simply imply a consistent fit. Additional findings specific to male surgeons suggested that males, taller individuals, and surgeons with larger hands have significantly more discomfort in the lower back, hips, knees, and their ankles and feet. Our analysis showed that female surgeons are more likely to receive treatment for their hands, which includes the wrist, thumb, and fingers, with an odds ratio of 3.5. The ergonomic problems faced by female surgeons pose new challenges for the manufacturers of surgical instruments and equipment because the dimensions of optimal ergonomics may differ widely from male and female surgeons. Though they have spent significantly less time in practice, women reported more shoulder area pain and received more treatment for work-related hand injuries than their male counterparts. Specific causal relationships are still needed in order to proffer ergonomically significant solutions. Recent evidence suggests that there are sex differences in muscle coordination of the shoulder girdle during a sustained motor task performed with the upper limb positioned below the level of the shoulder area. This is consistent with laparoscopic operating. In a recent study of 17 healthy females and 21 healthy males, females had higher normalized muscle activity for the upper trapezius and serratus anterior muscles compared with males when performing the same upper pectoral girdle activity. And so the question becomes, is the robot the great equalizer? So I too referenced this study, which was a comprehensive assessment of the ergonomic impacts of operating, where finger fatigue and neck stiffness predominate. And I found that while the authors implied that there were no gender differences present, the paper itself did not present a statistical analysis that supported that conclusion. And last, we consider only the surgeon in the room. I didn't turn those, sorry. And last, if we only consider the surgeon in the room, let's recognize too that the first assistant suffers, that the camera navigation also poses significant ergonomic risk, that body posture then compensates for ergonomically unfavorable conditions, and that the first assistant is found to bear their weight on their left leg in 70–80% of their weight. And so finally, question becomes, whatever is a surgeon to do? And I believe our last speaker will present some solutions.
Thank you very much.